Hello everyone, my name is Jen Nolan and I'd like to welcome you to the 8th webinar in Move Muscle, Bone and Joint Health's 2017 Musculoskeletal Health webinar series. Tonight's webinar is on the topic of fatigue management for people with persistent pain. Our presenter for this evening is Miss Fiona Thomas. Fiona is an occupational therapist and is working at the Caulfield General Medical Centre as the Senior Clinician, Occupational Therapy in the Caulfield Pain Management Team. Fiona graduated in 1986 and has worked in a variety of clinical areas including hand therapy, industrial musculoskeletal rehabilitation and chronic pain management. She has worked in both private and public settings as a clinical OT, program coordinator and educator. Fiona has a clinical interest in relating OT practice to pain management, including goal setting, functional capacity assessments, activity engagement, biofeedback and sensory processing, self-regulation, as well as applying modern pain science into OT approaches. Without further ado, I'll hand proceedings over to Fiona. Thanks very much, Fiona.
Okay. Hello, everyone. So, as Jen was saying, today we're going to look a bit about fatigue management. And obviously, when we have patients coming through the pain clinic, while most of them will come through with a primary complaint of pain, they just going to go back up to here a bit. They will also quite commonly say that they are experiencing quite a lot of fatigue as well. And while this may not be their primary complaint, it equally has quite a lot of issues for them when it comes to how they're managing their condition and how they're managing activity. So often as OTs, we start to find some of these more complexities that sit around their physical status. So it's always interesting to ask that question of what actually is fatigue, and fatigue means many different things for many different people. And obviously there are a lot of medical conditions that are associated with fatigue, but for the purposes of tonight, we're looking probably more specifically at what we commonly see within a pain population. If you were to look at the general population in Western society, you would find probably about 6 to 7.5% of people complain of having fatigue that is ongoing and is interfering with their daily living, to the point where they may well visit the GP due to their significant fatigue. And in Australia, that's about 1.5 million people a year. So it's quite a common symptom in the general population, and an even more common symptom amongst the chronic pain population. We know that fatigue can be very variable in duration. So for some people it may be just a short-term thing. It may be related to a short-term illness or a virus or a bad night's sleep, but it can also be chronic and prevailing, so that it's there all the time despite having a good night's sleep, and in itself becoming quite an issue. In terms of how you define fatigue, I think it's important to understand it from the patient's perspective. They might have their own definition as to how they tag an experience as being fatiguing, but generally it's this sort of difficulty or inability to kind of initiate an activity. It's often associated with this kind of reduced capacity to maintain an activity. So once you've started an activity, to be able to actually finish it off is difficult. But it also comes with mental fatigue as well. So people will often complain that they can't concentrate very well. It's really hard to kind of remember things, remember where they're up to. And sometimes it's also associated with emotions as well, that they feel kind of demotivated or feeling tired or feeling a bit down or sometimes a bit anxious, particularly if they're worried that they're not going to be able to finish off the activity. We know that it's generally higher in women than men, and it's a symptom, not a condition in itself. So it can be caused by a wide range of factors. And so part of the treatment process is obviously trying to eliminate those factors that may well be easily treated. It is more than just feeling drowsy, and it includes tiredness even after you've had a really good sleep. But people will often complain that they don't feel as though their reflexes are good, their eye-hand coordination is down. As I said, they often have short-term memory problems. Sometimes they report visual changes. And they usually sort of say they feel that they need to sleep more, that they're not getting enough restorative sleep. So the causes of fatigue are, very, very broad. Obviously, for the purposes of tonight, we're looking at it more primarily within a pain population, but it's important to make sure that any other medical causes of fatigue are ruled out. And obviously, within the pain clinic, that's part of the role of the doctors in their initial assessment, is to determine, is it related to things like a thyroid disorder? Is there a comorbid diagnosis with sort of heart disease or cancer or diabetes, common medical conditions that might be associated with fatigue? It can also be mood related, so a lot of people who have a mental health issue around depression, anxiety or grief may well also report that they have this kind of enduring fatigue that doesn't seem to go away. But equally, it can be idiopathic. It can be for no other reason except that fatigue happens to be their principal concern and there's no clear trigger as to why they feel tired. And then the other area is probably lifestyle related. So there may well often be certain aspects that patients can identify that they feel is directly related to their fatigue. Common one being poor sleep, but it can also be related to stress at work. They could be doing shift work. They may be having a small baby, and so their sleep-wake cycles are disrupted. And it can also be related to alcohol or drugs or medication that they're taking for their condition. So when we're looking at it, how do we then assess fatigue? And then when we're looking at it within fatigue and persistent pain, so I'll just go back a step, is when people with persistent pain, as we said, commonly report fatigue, but equally those with chronic fatigue commonly report persistent pain. So there tends to be this sort of bidirectional relationship. And so while we apply biopsychosocial models to pain, we can probably also apply similar types of models to managing fatigue. And equally, like we might talk about acute pain as having a protective factor, making sure that the person is looking after themselves in the presence of threat, fatigue and acute fatigue may also have a similar role in that it has protective properties. It forces us to rest. It forces us to restore our body when it's in the presence of some form of threat. When we look at the combination of pain and fatigue, they have a number of factors in common. So people with fatigue don't sleep well, neither do people with pain. It's commonly associated with those mood changes. It changes the type of activity and exercise that we might do. So people start to become much more avoidant of certain tasks for the fear of either triggering pain or triggering fatigue. It's often associated with stress and fear. When you're not quite sure how you're going to be, you're a bit worried about, well, what will happen if I'm out and I'm tired or I'm sore and I can't do what I want to be able to do. That in itself also creates stresses if you can't complete those roles that are important for you. Medication, again, it can be a large source of what people feel fatigue-wise, and we know certainly in pain a lot of the medications that are commonly used are also associated with that kind of somnolence or sleepiness. And then, of course, the cognitive changes are quite present in pain, as we find also in fatigue. So when we're looking at assessment, as I said, usually at some point they need to have a good medical and health screen. This is more often not done by their doctor. And we might, within our assessments, just double check some aspects that relate more to general health knowledge and behaviour. So, are they getting a good diet? Are they getting a good sleep? What are some of the medications that they're actually on? Are there any other psychosocial stresses that are around at the moment? And the doctors themselves will look at some of the aspects around medical history and any other potential medical triggers or causes to fatigue. And then from there, it's kind of getting an understanding of what that fatigue means for that person. So when did that fatigue come on? Now, some people might say, look, when I think about it, I've been tired for quite a few years, maybe even before pain came on. Or they might say, look, no, it's only been a fairly recent onset. I had pain, and then just in the last sort of 12 months, I'm noticing that I'm really, really tired as well. And then we can look at the cause. Is it intermittent? Is it variable? Has that fatigue been the same the whole way through? Does it have a variation? Are there periods where they find that the fatigue isn't present or it isn't a big issue, or periods where, it's really impacting on what they do? And does it have a daily pattern? Do people wake up tired? Do they tend to go to bed at the end of the day and they're more fatigued than normal? And how do they kind of respond around that normal times when we might feel fatigued? So does it follow a normal pattern or does it have a more abnormal or maladaptive pattern? And what kinds of things, trigger that fatigue? So, people might say, well, it's whenever I have a bad night's sleep and that's when I'm tired. Other people might say, well, I notice it when I'm under a lot more stress. Some people will say that there doesn't seem to be any kind of trigger. It just comes on and I'm not really aware that it's actually come on. And do things relieve it? If they get a good night's sleep, does that improve their fatigue? If they have a rest, does that tend to improve it? Or does nothing seem to really change those levels of fatigue? Obviously, from an OT perspective, I'm then also quite interested in what's the functional implication of fatigue. So what are some of the activities that people may still be doing? What are some of the activities that they're actually now starting to reduce or to be much more careful about the way they do it, and some of the activities that they've completely disengaged from because they found that they've got that fatigue. And again, sometimes that fatigue may not be present when they start an activity. It may well be something that happens at the end of the activity, or maybe something that's a rebound effect the next day, and they go, okay, I felt all right at the time, but then the next day I was absolutely so tired I couldn't do any activity. And then we look at, well, how's that person then adapted or responded to that fatigue? So what are some of the behaviours that they've put into place? Are they tending to avoid things? Are they pushing on irregardless? Are they starting to use either different medications or kind of off-the-shelf things to either increase their alertness or to help them, sort of more relax? Are there changes in the environment? Are they having to ask people more for assistance or help? Are they starting to disengage from some of the roles that they may normally have done within their environmental context? I guess the thing then to think about is, well, then how do people then define their fatigue? And I've put this sort of bit about interoception, the sort of capacity of the mind to focus its awareness on what's happening within our internal state and within our body. And we know within the pain population that sometimes people have a real difficulty to kind of work out that build-up of pain. And equally, people can have difficulty working out the build-up of fatigue. So sometimes it seems as though it comes out of left field, and then when it's there, they have to really wait for it to kind of settle down, as opposed to being able to pick it early and put some strategies in earlier. We know interoception, that capacity to pick up what's happening, is really dependent on that flow of sensory information coming in from the body and also from the environment around it. So sometimes people may well be very keyed in as to what's happening in their body, but not what's happening in the environment around them, or vice versa. And so what they might think of a flow of sensory information may not be bringing in all the information to allow them to accurately determine kind of when that fatigue is starting or what might be triggering that fatigue, which will obviously impact on their ability to self-report it within an assessment. So fatigue is going to mean different things to different people and the context in which it's experienced. And we need to, in our assessment, really get an understanding from the patient's perspective what it means to them, not necessarily just kind of how they're reporting it, but more about the context and the fabric that goes around that fatigue as well. So there are lots of different ways of assessing fatigue apart from just the subjective component of our assessment. There are a few scales that you can use for measuring fatigue, and I've included a few here. One that's used sometimes in research is the Cholder Fatigue Scale, and again that's almost a little bit small, but again it asks a few simple questions and then kind of determines what's the frequency of you actually being able to feel that. And so it's a good way of kind of getting a bit of a baseline of where people are at. Equally, the scale on the other side is kind of a little bit of a funny one. It's sort of somebody's kind of ranked their hierarchy of what fatigue is, from 10 where I can barely move and can't talk through to 1 I can go clubbing. Sometimes, I'm not necessarily saying that that's a scale you use all of your patients, but sometimes it's really good to sit down with them and actually get them to write out their own hierarchy. What does 10 mean for them? What does 1 mean for them? What does having energy and feeling as though there's no fatigue, what does that mean for them? Versus how do they know when they're fatigued? What are some of the things that happen for them? And then you can actually use that hierarchy over time as a bit of a rating scale. Where do you feel you are at this point in time? How do certain activities make you feel? And then obviously, from a functional perspective, there are a few good assessments, and this one in particular is mainly designed as a sleep questionnaire. It's sort of functional outcomes of sleep questionnaire. But again, it asks questions in a very specific functional way. And so it means that you can use it as a way of initiating some of that discussion with patients about how they're noticing their fatigue, how often it has, how much difficulty it impacts upon their own actual functional activities. And it goes through a whole range of things from concentration to doing daily activities to, sexual function and so on. So it's quite a nice broad sort of assessment, and again can be used as a good baseline assessment to go, okay, this is where you are now. After doing some treatment, where do you end up with after that? So looking at treatment approaches, I guess I've divided this into two sections. The first section is perhaps the common approaches that we use with fatigue, and some of the pros and cons that go with it. And then in the second part is perhaps looking at perhaps some more creative ways that we can use some of this information in a treatment way. So obviously when people have got fatigue, you start with the most simple thing, and is that, are they getting a good night's sleep? And if their sleep is not good, then it's probably worthwhile looking at exploring some sleep techniques to improve the quality of their sleep. Now, for some people within pain, often the sleep issue is that they can't get to sleep or they can't stay asleep because pain is impacting upon that. We do see a few patients with persistent pain who may have also had a co-diagnosis of chronic fatigue syndrome, and that probably presents a little bit differently for them in terms of their fatigue. And so they might actually find that they're sleeping too much, and they find that they've got to sleep about 10 hours to actually get enough to feel restored. So again, they might need some very different sleep techniques to kind of narrow down some of that sleep time. In terms of those that have more insomnia or more reduced sleep, we may look at things like stimulus control. So that's trying to get them to associate that bed is for sleeping, and that if they haven't got off to sleep within about 15 or 20 minutes, they may need to just get out of bed and wait for the next wave of sleep. So they're not starting to associate bed with being wakeful. They might use some sleep restriction techniques. So again, these are good CBT-based techniques where they're limiting that time in bed to sleep only. So if you only sleep 4 hours in bed, then you spend 4 hours in bed. What tends to happen is people get quite sleep deprived because they, are wanting to try and catch up on that sleep and rest, but they're not necessarily getting good quality sleep. So what it does over time is increases the drive for sleep, and then it helps to consolidate that sleep. So they get improved sleep efficiency over time, and then they start to spend longer time in bed. The other common technique is sleep hygiene. So that's improving the patient's awareness of behavioural environmental factors on sleep. So things like, what's the level of light in the bedroom? What's the level of noise? Are you, drinking coffee and Coca-Cola before you go to bed? Is the environment comfortable? So do you have a good bed? Are you, is the environment too warm, and that's impacting on your ability to go to sleep? So they're very simple strategies that people may be able to apply to help that kind of sleep pattern. We may also do relaxation training. So again, trying to reduce the arousal levels, because the whole point of sleep is we can't go to sleep very easily if we're in a high state of arousal. And so for some people, particularly if you've got pain, that high state of arousal is often there. And then if you start to associate not sleeping very well, it's going to get even higher. So it's trying to reduce some of that tension. We do lots of education about sleep and what sleep actually means and why we need to sleep and its restorative effect to help sort of reduce some of the fear and identify helpful behaviours. And then finally, some of the psychologists and even the physios and the OTs may work a little bit about exploring some people's beliefs and attitudes towards sleep that may be impacting upon their sleep behaviours. So ideally, if we can improve their sleep, that might improve their fatigue. If not, what we might do is look at some energy conservation types of strategies. And these are really identifying things that deplete people's energy, that have an impact on their energy levels. And the idea is to try and minimize energy loss or balance energy loss with energy restoration, so that we're working within a certain context of the energy that they have. To do this well, you need to have a good systematic analysis of what that person's activity is and how to modify that activity. And again, it means different things to different people. If you sometimes people like apply, a meta-analysis of an activity. Now, you might have 5 people who do their vacuuming, and they may use very, very different levels of energy to do one particular task. So while you might have to analyse the activity, you've also really got to analyse how that person does that activity to get an idea of how much energy is used within that. There is some evidence for effectiveness, but really the evidence on the whole is fairly low, and it depends on the population that they've explored that fatigue. So there's been a lot done within multiple sclerosis, a lot done within cancer, a little bit done in chronic fatigue and in pain as well. But again, the overall evidence is fairly low. And I suppose some of the things that we think about, a bit like happens in pain when we talk about pacing, is that are we actually encouraging a level of activity avoidance through energy conservation techniques? And over time, is that actually impacting on ongoing fatigue rather than helping to reduce it? So some of the principles of energy conservation is setting up proper working conditions, so making sure that what you're doing, you're working in an efficient environment, you're eliminating any unnecessary motions, you're trying to alternate what you're doing with a high energy load and then an opportunity for a low energy load. Getting people to avoid rushing, and this is really common within the pain population. They figure I've got to get it done really quickly before I'm sore, so there's that tendency to kind of quickly get that task done, which uses a lot of arousal, which uses a lot of energy. Breathing techniques, considering other external factors like the weather, person's weight and age, their emotions, trying to get people to stop and rest before they get tired, and this can often be really hard if they're not picking up that they're fatiguing or getting tired. You may employ assistive devices, so using like a trolley to take the washing out to the washing line, a stool in the kitchen, and also encouraging patients to delegate tasks as well. So they may not have to do the whole task, but are able to do the components that they want to do. So again, very, very simple, common approaches. The other one is activity pacing, and there's probably a lot of similarity between energy conservation and activity pacing. Activity pacing, again, is allowing an individual to be active but within their physical and mental limits. So again, it works on what's called an energy envelope theory, so that you maintain expended energy within that energy envelope through moderating the type of activity you do, trying to conserve energy, and then over time maybe encouraging increasing levels of activity to try and expand the energy envelope out. But again, when it's used just on its own as a sole treatment technique, the evidence is still fairly low as to how helpful it is. And I think one of the issues is that a lot of these types of techniques are, kind of either researched in a much more multidisciplinary approach. It's one component of a treatment, and it's very hard sometimes to take it out on its own context to determine how effective it is alone. One research that I've added in here where they looked at self-management using activity pacing for chronic fatigue, and how they kind of described the sort of sessions that they used was really to have a stabilization phase where they kind of really got everything under control. They were trying to work out what that person's capacity is before they started the activity, and then teaching them techniques to work within that capacity. So it was kind of a learning phase, a stabilization phase, and then they introduced a graded phase once they had reasonable control over their fatigue. And that was about really trying to increase their levels based on goals that they may have developed from the Canadian Occupational Performance Measure. And the frequency of this was about 3 sessions of OT a week, about 60 to 90 minutes per week for about 3 weeks. So it just gives an example of, okay, that's one kind of program, but there are lots and lots of different programs. So when you're comparing, is activity pacing, working across a whole lot of different research articles or programs, again, they all may well be very different in the way they've actually structured it. So that's another problem when we're looking at research into how effective these types of approaches are. And then further on activity pacing, another research just to show how sometimes we get absolutely no evidence that they're helpful at all. This particular study was again looking at chronic fatigue syndrome, but it was looking at pacing activity on fatigue and pain as well in a chronic fatigue population. And they used a number of different measures looking at coping inventory, a pain rating scale. They used the shoulder fatigue scale, which we showed earlier in the presentation, and the fibromyalgia impact scale as their outcome measures. And what they sort of found was that the results failed to show any significant associations between pacing and a person's level of pain, disability and fatigue. So there didn't seem to be an association between them. And what's more, when they actually put through a program of changing people's pacing techniques, it also failed to show any significant association with pain, fatigue and disability post-treatment as well. So again, you've got results like this saying, well, there's perhaps no effect. Other results saying, well, yes, actually there may be a smaller effect. And then, of course, we've got fatigue management programs, and again, they probably have a combination of a whole lot of things, including activity pacing and energy conservation, but may also have some aspects around body mechanic education. Some may well have graded exercise programs involved in them. This is an example of one that they were using as a one-to-one fatigue management course, and again, they looked at how effective this program was, looking at it if you delivered it one-on-one or versus group, and they certainly found that there was not much difference whether it was delivered one-on-one or in a group-based format. And again, they looked at self-efficacy for performing those techniques and energy conservation strategy surveys, their outcome measures. And what's interesting is the things that they actually covered. They did it in 5 modules. So again, lots of education about what fatigue is, looking at communication and fatigue, how to use body mechanics and making the most of your environment. They did analysing and modifying activities so that they could work much better within the energy envelope, and then really trying to get people to develop a more balanced lifestyle, as well as sort of handouts on cognitive fatigue and secondary fatigue and things like that. So it's a nice little module, but it's covering more than just sort of energy conservation or fatigue management. So it suggests we need a little bit more to kind of work on improving the way people manage their fatigue. And then the other one is graded exposure. So again, graded exposure is used a lot within pain management based on that fear avoidance model, and possibly can we apply that to the fatigue model as well. One of the things I notice within my patients is that, their symptoms of fatigue can be easily aggravated, just like pain can, after just a minimal amount of activity. And what happens over time is they start to avoid some aspects of activity because of that rebound effect of both pain and fatigue. And so with time, we end up getting this sort of deconditioning, downward sort of spiral cycle in an attempt to sort of minimise the impact of fatigue and pain on daily living. And that's a really common thing that we see within the pain management program. However, what they have certainly done a really big trial that looked at pacing, and this trial was primarily in chronic fatigue syndrome, and it looked at CBT techniques, which was based on that fear avoidance theory. They looked at graded exercise therapy, and they looked at adaptive pacing therapy, which again was based on that envelope theory, and trying to optimize adaptation to a person's illness. And there's probably been a lot of controversy around that particular research, because it was a very large research done in Britain. And while some articles will say that there was some improvement with the CBT and the graded exercise, but no changes at all with the adaptive pacing, more recently perhaps some of the results have been contested a little bit more, and really sort of feeling that perhaps there was really no significant improvements using any of those sort of techniques on their own based on some of those objective measures. So again, there's not sort of clear research that one thing's working much better than another, and maybe graded exercise therapy is not always a good approach with people with chronic fatigue, but it may well work reasonably well with the pain population where people have got fatigue. So I guess what I'm trying to look at now is, well, can we, instead of sort of having a more generic approach to how we manage fatigue, can we really apply it to the person and that person's fatigue? So can we individualize it for the person? And if we consider it within our brain systems, they're all different triggers when we have pain, different triggers when we have fatigue. We have psychological responses around that, and that might drive the types of techniques that we might use with that person. So, for example, someone who does demonstrate that there's a lot of fear and anxiety about their fatigue or about their pain may well respond better to an exposure type of treatment where they've got graded exercise or graded activity approaches. Someone who may have more issues around kind of stress regulation and autonomic regulation, where they're not sleeping well, they're having issues with kind of bringing their arousal to a level that's not so energy burdensome. They may well respond better to sleep hygiene techniques and stress management-based techniques to dampen down some of that arousal. For those that may well be struggling with their fatigue more around motivation and getting up and going and sort of being able to move forward, they may do better with some goal setting to begin with and just really working step by step towards building a much bigger activity level. And then those that really have difficulty working out when fatigue happens and when pain happens, they can't pick the build up and end up sort of being hit out of left field by it, they may well do better with treatment techniques that are around interoception, building their awareness of their internal state, and more self-regulation based techniques based on that. So if we look at those in a bit more detail, we can look at, sleep management side. Can we apply perhaps some of the CBT approaches to insomnia to manage pain and fatigue? We certainly know that poor sleep at night can contribute to pain intensity and reports of pain. This particular research looked at a whole lot of different outcome measures that were based on sleep and fatigue and sleepiness, as well as chronic pain, catastrophizing, and kinesiophobia. So they basically put everything in there almost, and then collected that data over a number of different data collection points in older adults with OA. And what they found is that if they really targeted the insomnia in the first couple of months, really focused a lot of their attention on that, and people were able to sustain their sleep outcomes, these were associated with long-term improvements in pain severity, arthritis symptoms, and fatigue at the 9 and 18-month mark. Whereas the results with those that didn't maintain their insomnia as well or didn't develop good sleep strategies, they didn't get as good improvements over that period of time. So maybe one of the strategies that we need to have is actually tackling sleep very early, particularly if it's disturbed, but also getting a good sleep pattern in place. Another approach that we're using a lot more within the pain clinic is trying to develop using some of the sensory processing literature that really was probably more commonly used in pediatrics and to a certain extent in mental health, and applying that more within the pain population. And I guess the idea of the model of sensory processing is that we all have different levels of threshold of information that we notice. Some people will notice everything and only need a little bit of information to notice it. Others actually miss a lot of sensory stimuli. They're not really good at fast presenting type of information, and so they need really quite rich information to be able to tag what that actually is. And then people may well develop behavioural strategies in response to those particular styles. So some people seek to put more information in to the system. Some people really seek to contain it so that they're not overwhelmed or overflowed. So when we apply that to fatigue, if you've got someone who's got an underreactive system or very high thresholds, you need to probably build more awareness with those people. With those that tend to have an overreactive system, so they have very low thresholds to sensory information coming in, we perhaps need to focus our treatment more on building resilience. So we know fatigue is high when we have overload of this external stimuli and low when the stimulation is attractive. So if we're really enjoying and we're curious about that stimulation, we feel more alert and more engaged. If it's too much, then we feel overloaded and we start to switch off. But equally, if there isn't enough information in the system, we can equally feel quite fatigued and disengaged. So it's trying to get the amounts right and building patients' awareness of that. We know that fatigue is an internal cue that can be heightened when there are either too few or too many external demands. And we often focus on having too many, but we also perhaps need to focus on too few. And what happens with fatigue and pain is we start to curtail those demands that are coming into our system. So therapy is trying to really reestablish that balance between what's happening internally and externally with the way we process information and the demands that are placed on the nervous system, and really trying to get people into that middle level of arousal where they're not too much arousal but not too little arousal, so that they can really maintain good sort of activity patterns over the day and hopefully good sleep patterns as well. Another approach is looking more at the sort of the functional restoration and looking at things like graded exercise programs, building better activity patterns and sort of more that biopsychosocial approach, but where it's very patient-centred. So certainly there was a Cochrane review that looked at exercise and physical activity within pain, and again some of the evidence for that is can be low as to whether that's actually helpful in managing pain. It's very good at managing general health and general fitness, but it may not always change people's pain experience. When we look at activity patterns, one of a research technique with experience sampling, where you actually get patients to note in real time what they're actually doing, we noted that patient symptom experiences tended to drive their activity management patterns. So things happen fairly quickly. They take in how they're feeling, and that influences the decisions they make about activity, whether it's to rest, whether it's to push through, and so on. But it's happening in a very short period of time. The other aspect, looking at biopsychosocial approach, again being very patient-centered to work out what's the impact of pain and fatigue for that particular person, and what some of their attitudes and beliefs are around about recovery. How confident are they if they do these types of processes or interventions, it's going to actually help them manage their pain. Sitting down and actually goal setting to identify what are their priorities, values and motivations, so that treatment's really targeted to the areas that are going to actually attract their interest and attention. And then building their confidence and working out where are they confident to be able to look at what's that baseline. What are they confident that they can actually do? And that might be the point where we start, so that we're actually creating success for people rather than reinforcing failure. And then the other important thing is to provide opportunities for positive experiences to build self-efficacy. So rather than treatment always just being on a talking level, we also need to build doing, not just in a clinical environment, but also in people's own home or work-based environment, so that they're starting to feel confident they can apply these techniques in lots of different ways and embedded in their own sort of social and environmental setting, rather than just a kind of a treatment that doesn't necessarily make linkages to what that person, how they live and what they actually do. And then combining some of these approaches. So if we sort of think about, you've got a patient that's presenting with persistent fatigue and persistent pain, obviously we do a good multidisciplinary assessment to determine what are all those contributing factors to fatigue and pain, what their current functional level is, and that gives us a good baseline. And then just like we would do neuroeducation on pain, we also need to do it on fatigue and stress and arousal and that impact on a person's sort of homeostasis or sort of balance. From there, working with the patient to determine where they want to get to, what's important for them, and identifying target functional areas. But really individualizing that goal setting so it's meaningful for the patient themselves and at a literacy level that's meaningful for the patient too. And then with that patient, identify the key areas of where they might want to start in treatment-wise. So what are going to be some of the enablers that are going to help them manage this better? What are some of the disablers? And how will our treatment intervention really be designed about improving their skill base and really starting to reduce the things that are actually getting in the way? And we can use lots of treatment techniques with that. We might use activity diaries. We might use some of the apps that are available now on phones or activity monitors. Again, using activity adult sensory profiles to kind of, allow the patient to actually build an improved awareness of how their nervous system functions. What are their normal habitual responses? Do they tend to avoid things? Do they tend to be unaware of things? Do they tend to actually push through? And that's half of what the problem is. So using all of that information to then really develop a patient-centered treatment plan that's based on those sort of agreed targeted areas. So they're really in control of what they're doing, and then monitoring that progress based on that functional engagement. And making sure that some of those maintenance options that happen later are not facilitated within a clinic environment that usually has a beginning and an end, but is really something that's accessible within their own community and is enduring. So there's no point having, strategies in place and people, are able to engage in it, and then, okay, it's the end of that particular 6-week program and there isn't anything else there in place for them to continue on with. It's a wasted opportunity. So we need to make sure that all of that process is thought of when we're developing treatment plans for our clients. And then one of the other things is really also trying to educate the patient about really focusing more on healthy living and healthy balance rather than just on perhaps the symptom that's causing them the most grief. So often when people come into a pain clinic, they expect us to be managing or fixing their pain. If they're going into a chronic fatigue clinic, it's probably managing their fatigue. But at the end of the day, what we're really trying to do is improve people's general health, both mentally and physically, so they're better able to cope with some of the issues that sit with their pain and fatigue. So there's a really good website that's by Dan Siegel and David Rook called the Healthy Mind Platter, and patients really kind of get this, where what they're trying to do is developing good mind habits that optimize their brain and body function, and focusing the treatment for patients based on getting this really good balance. So sometimes when we're looking at pain and fatigue, our focus may well be more or too overly focused on physical activity or reducing psychological distress and maximizing functionality, which are really important. But we know people are very complex, and their daily experiences are more than just that they go to bed and they get up and they do things. So the Healthy Mind Platter really encourages people to think about getting time. It's focus time, so really, goal-orientated tasks that they can really focus on, but also having playtime, which is spontaneous and creative, having connecting time where they engage or re-engage with other people, having physical time where we do move our bodies and we engage in activity, but also having time in where we may give ourselves some opportunity for internal reflection and build our own awareness of what's going on emotionally and physically in our body, having some downtime, which I sometimes like to call mindlessness as opposed to mindfulness, but it's just time where we may daydream. We just kind of put our brain a little bit online for a period of time. We don't have to be on alert all the time, and also making sure we get good sleep time, that we're actually giving it the priority it deserves, because we know good sleep is important for our general health. It's certainly important for how we manage our pain and how we manage our fatigue. So should we perhaps be targeting our therapy much more towards a sort of healthy mental and functional diet, rather than necessarily just specifically on the symptom itself? And I think that's probably an important thing we need to think about as we go forward. So hopefully that's been helpful, and I'll start to kind of, take some questions. But thank you very much for letting me have a chance to come and talk to you.
Thanks very much, Fiona. It's such an important area, and you've really sort of covered it very comprehensively, which is great. We have a couple of questions that have come through, and people will notice that the survey regarding the feedback is also up on your screens now. Mm-hmm. Early on, you mentioned a link between chronic fatigue syndrome and persistent pain. The person also, Marcel, mentioned that there's also a link with irritable bowel syndrome. Have you found an improvement in any of your persistent pain patients that have improved their gut health, especially when so many with chronic fatigue have also Epstein-Barr virus and excessive antibiotic use?
Yeah. And look, I mean, we will see a lot of pain patients, and when you look at their medical history, they have IBS in their medical history. They might have chronic fatigue, and it's almost like there's this cluster of symptoms that often commonly go together. There's probably a lot more research now that's looking at if we improve gut health, are we actually improving pain? And there's certainly some, positive aspects within that research, I think, as well. And what we're tending to do a lot more now is actually seeing whether it's worthwhile getting our patients to see a dietitian, to look at actually perhaps developing a better diet, and whether that actually helps some of their pain and fatigue symptoms as well. So I think as we move forward, we're going to see a lot more about improving gut health as a pain management tool and possibly as a fatigue management tool.
And also comment from myself, mindlessness is something I've been reading a lot about lately, and it can be called white space, where there is nothing scheduled in our busy lives. And I'm not quite sure, that's not quite a question, but probably more of a comment.
Yeah.
Any comment from you, Fiona?
Well, I think it's a good one because, it tends to be this modern thing that we have to be productive all the time. And it's one of the reasons why we probably don't sleep as well as what we should, is this sort of feeling of, sleep's just getting in the way of what we're doing, and doing is about being successful and, being on top of, what we do. So this concept of actually just having white space, of daydreaming, of just having time out, has really negative connotations for people. They feel really guilty about doing it. But it's quite possible it's a really important part of how we maintain our mental health. We don't need to spend our whole day being mindless, but we probably need to, have parts of our day where we feel quite comfortable doing that.
I think that's very true. Also another question, and actually came to my mind as well, with regards to, and even around the time of that initial assessment, does it take long for people to actually sort of catch on to thinking about some of the things that you're wanting to sort of gather information on early on? Paul is asking a question about how long does it take the process really from sort of assessment to hopefully a satisfactory outcome for someone in your clinic?
Yeah. And look, I think that time really varies, and there are so many factors involved as to how well people pick up a self-management approach, which is really what we've described tonight. Sometimes people have things that really get in the way of them taking that on, and it may well be, other mental health issues or other health-based issues. They may well still be searching for some medical solutions to their pain and their fatigue. Some patients will pick it up really quickly. They just come to the assessment, and the assessment has almost been a therapeutic tool, or they may have come to one of our initial education sessions, and by the time we see them, they're saying, look, this is the stuff I've already put into place. I'm already noticing that there's an improvement with it, and those people may well have a very short time within the clinic from beginning to end. Other people really have to actually build some life skills. They come to us with very few life skills, and we're actually having to build up some of the scaffolding that allows them to then take on some of those self-management principles. So, for example, if you've got someone who has poor awareness of their ability to manage their arousal levels, they go from high alert to kind of shut down all the time. They're not going to be very good at approaches that really require the brain to be engaged all the time. And so that's maybe not the good place to start. We might need to use a more sensory motor sort of bottom-up approach first to get people able to get a good scaffold in place before they can actually do some of that more CBT-based type of therapy. And those people may well take, almost a year within a pain clinic to really start being independent with using some of these strategies.
And Fiona, a comment and question from Wendy, who's an RN and works in an acute setting delivering ketamine and lignocaine subcut for a week as an inpatient. I find that these patients often suffer from side effects, so I find it difficult to encourage them to do anything. Is there a small, simple tool I could utilise to encourage these patients to try to engage in a small activity?
Yeah. So one of the things that we sometimes do with patients is think about having I call it a sensory box, but how you would describe it really depends on the client. So you might say, look, this is an activity box for when you're actually either, within the inpatient setting, and we also use it at home or in the clinic setting, and then the patient works out what should go in that box. So if they're really wanting to kind of build their alertness, they may put in things that, might be, some brain games. It might be mindful colouring in. It might be origami, just things that they can kind of, because often they can't, when they're in a state of feeling uncomfortable, they don't always find it easy to think about what to do. So therefore they do nothing because that's kind of easier. So if they've got something where they just have to think, okay, I've just got to get that box out and then work my way through it. Now we sometimes put little relaxation scripts or CDs in there. We might even put, kind of squeezy balls, so they're doing a little bit of, activity. We might give them a little bit of a stretching program, and it's just prompting them that these are small things that you can actually do. And by doing them, you might actually improve that level of alertness and decrease that level of fatigue. Because it's not always rest is good for fatigue. Sometimes if we actually build activity, we may actually reduce some levels of fatigue just through actually doing more rather than doing less. So I don't know if that kind of helps answer your question.
Actually, it's interesting you mentioned the physical activity, Fiona, because it did occur to me that there's also that sort of correlation between the less activity you do, the more your sort of fatigue builds. So I was interested, you mentioned research that didn't show much impact with regards to physical activity and the impact on chronic pain. Any further comment there with regards to the role of being physically active for people suffering from pain and fatigue?
Yeah, look, I think probably the issue around that research is that if you are determining if I do exercise, does that change my pain? That's probably a more tenuous link. In some people, it really does have a big impact. For other people, it actually just makes their pain worse. But we don't just exercise to fix our pain, we exercise to also manage our general health. And, I think it's important to get across to patients that while you might not find your pain changes in the short term because you're exercising, you're going to start sleeping better, you're going to start having a much better balance in your daily kind of general health and activity levels. It's going to reduce your stress levels, and over time, that might actually change your pain. So it's really just giving it a different context, I think.
Paula's questioning about whether this treatment is available to be administered by all physios or OTs. I'm not particularly clear, Paula, exactly what treatment you're referring to there. Just if you want to clarify that question. Fiona, just one other thing. I was interested with regards to the research not showing a lot of impact in relation to activity pacing, which I thought was actually quite a key element of fatigue and pain management.
Yeah, look, it is, but again, and we find it very much the same in pain management, that if, is pacing truly effective, and if pacing is actually encouraging avoidance, what is happening is you're doing less over time, your energy envelope is reducing over time, so that you notice that you're more fatigued from doing less. So I think when we talk about pacing, we have to be really careful. It's not all about reducing what people do. And in fact, sometimes pacing is actually upgrading what we do, not downgrading what we do. But we commonly associate it in fatigue with doing less. Possibly we need to think about it's actually about doing more, but in a way that patient actually manages it well, so they're not booming and busting with that level of activity. And you've got to be pretty clear, I guess, where you start with the patient. You start where they feel confident.
So clarification there from Paula. Paula's wondering whether this fatigue assessment and management approaches could be available to be administered by all physios or OTs.
Yeah, absolutely. I mean, I think they are generic types of treatment approaches, and physios and OTs will bring in their own, and psychologists as well. We all use these techniques, but we bring in our own biases around it. So obviously physios might use a lot of it within the context of exercise, OTs use a lot of it in the context of activity, and psychologists might use it more within the context of stress and arousal management. But there's certainly a lot of overlap, and that's, one of the advantages of working in a multidisciplinary team. Is that we get to feed a little bit off each other. It's probably a bit harder if you're a sole practitioner. But certainly, they're, apart from the sensory profile, I think the sensory profile is probably much more of an OT-based treatment, because I think it's much more effective if it's embedded in understanding the person's activity. It is an OT-based tool. So I would tend to say that's probably the way we use it. The OTs tend to do all of that assessment, but the physios actually really find that the information that comes out of the assessment is really useful in the way they structure their exercise programs.
And a question, have you found evidence to support engagement in meaningful activity and using this as a tool to manage the distress associated with the experience of fatigue?
Yeah, look, not a great deal, but I think it's actually a really good point, and I think it's more the fact that I think the link will probably be there. I just think we actually have to get out there and start doing some of that research, because I think activity kind of gets lost with a lot of other types of things that are looked at within research. So subjectively, patients will often report that when they start to engage in things that are meaningful to them, so not activity just for the sake of doing it, but when they're really engaged in the meaningfulness, they're building up that kind of curiosity and creativity, is that it does definitely dampen down distress. It's bringing them into what we call the window of tolerance, that kind of parasympathetic arousal where, they've got enough arousal to do the activity, but they're not kind of like in over-arousal. And if that's reducing the distress, it's probably also going to reduce the fatigue as well. But I think it's probably now up to us as clinicians to actually start doing a lot more research to look at the linkages of that in a more research platform rather than just in a clinical feedback platform.
And this could be a final question for tonight. Fiona, Paul is asking about who might she refer her clients to?
So I know where I work at Caulfield Hospital, we have a chronic fatigue clinic, and we also have a pain clinic. And obviously, you know, if a person's got pain and fatigue as well, there are probably lots of things that we can do. And a lot of pain management clinics would certainly cover both fatigue and pain, the combination. And we now have pain management clinics in quite a few. Most of the main hospital or hospital networks have them, but also in country areas as well, if you're more sort of country based. So that may well be one stop, but there are also a lot of private practitioners as well who work specifically in pain management, probably more so physio and psychologists. There are certainly some OTs out there, but maybe not as many. But you know, certainly, you know, doing a great job in the types of things that they do. And yeah, so hopefully that answers the question.
Actually, Fiona, does the Australian Pain Society provide any guidance with regards to practitioners or locations where pain clinics and specialists might be located? Yeah, so if you went to the Australian Pain Society, I think they've got a list of pain management clinics around Australia, and also probably how those pain management clinics are structured. So some of them may well be very medically orientated. Not all of them will have a very strong allied health component to it. So it's kind of good to work out that before you perhaps refer the patient there, depending on what the service is that you're looking for. I think we might have come to the end of our questions for this evening. And we're close to our finishing time. So once again, Fiona, thank you so much for a very interesting presentation, such an important area, and I think certainly the occupational therapy input within that sort of whole management of pain, persistent pain and fatigue is very, very evident, and shows the importance of it through the webinar tonight. So thank you so much for your presentation. I'd like to thank everyone for joining the webinar this evening. If you haven't already filled out the exit survey, please do so. I'll also remind you about our next webinar, which will be on Thursday, the 12th of October. It's actually free, and it will be on the diagnosis and management of rheumatoid arthritis. So I urge you all to register for that webinar. And on that note, I will thank everyone and wish you all a good evening. Good night.
Thank you. Good night.
Thanks, Fiona.